Good morning, everyone. I guess it's still morning. Thank you for sticking with us. And I guess I really took to heart Ken and Sean's description of this as a conversation. And so thought that I would just speak to you without PowerPoint slides. And I like to borrow frequently and often Mike Cohen's joke about doctors speaking without PowerPoints. He says he gets very nervous when he speaks without PowerPoints because he feels both powerless and pointless. So I love that joke. I did want to share with you some good news coming from New York City. I think it's important to hear some good news from New York City because, in fact, New York is the place, as we all know, that's had the largest epidemic in the country, in this country. And so when we make a large impact in New York City, it's fair to say that we make a significant impact on the trajectory of the burden of disease in the country. So here's the good news. As in the case in San Francisco, which is in fact the size of one borough in New York City, both our new diagnoses and our estimates for new infection are decreasing, both among all New Yorkers and among MSM overall. In fact, new diagnoses have decreased by more than 40% since 2002 in New York City. Now, we do have a situation where if you look at our estimates for incidence from 2006 to 2011, among MSM under 30, it looks like that trajectory is increasing a little bit, but our preliminary numbers for 2012 brings that number back down. So for young MSM, we look flat, and for overall MSM coming down and new diagnosis coming down significantly. People ask, last night people were asking Greg and others, how do you explain this? And I think there is a strong ecological argument to be made that it is improvements along our cascade that have made a difference. And the reason I can suggest this is that in New York, as you know, we have every year more and more people who are living and not dying from HIV. So we have a bigger and bigger pool of persons who potentially could transmit virus. We also have increased testing very significantly. As you know, you might know about many of our different initiatives, which I can talk about later. But our community health survey data now shows that nearly 7 in 10 New Yorkers have ever been tested for HIV. And that's almost double the national rate. And in the face of this increasing pool of persons with HIV and increased testing, and very little data to suggest significant changes in behavior, as Greg has shown, our new diagnoses are coming down. So that is suggestive, we think, of improvements along the treatment cascade. We have focused our efforts every step of the way, as Stephanie has shown, along the treatment cascade. And largely, we've been trying to make structural and legislative changes in these areas. And I'll give you a few examples now, and then we can talk more during the question-answer period. Many of you know that we changed our testing legislation in 2010 in New York so that we have a mandatory offer. It's an offer, so the mandatory part is for providers to offer the test to all persons aged 13 to 64 in clinical settings, meaning outpatient primary care settings, inpatients, and emergency departments in all hospitals. We have seen some small, significant increase in testing a year after that law. Again, this is a diffusion effect. And in New York, when we released a similar law in the mid-1990s around perinatal transmission, you saw the change took in New York really 10 years to have its full effect. We now have last year only 3 babies born in New York who were infected with HIV out of about 500 pregnant women in the whole state. So this does have a very significant impact, but it can take time. We have also focused on linkage to care. And as far as testing too, I wanted to mention large-scale community mobilization efforts through, many of you know about our Bronx Knows and Brooklyn Knows initiatives. About 1.4 million people tested, or tests conducted across both of those initiatives. So we're working to normalize HIV testing both through routine screening, but also using community mobilization efforts as well. And then we as well, on the heels of San Francisco's pioneering work, released an early antiretroviral treatment recommendation in December of 2011, which we believe has had an impact. And we're tracking that by looking at the percent of newly diagnosed individuals who are virally suppressed at 6 months and at 12 months. And we see an increase every year in that measure as well. In terms of NPEP and PrEP, this is where we're doing some new work, and we're working with our community partners. We'll go into some of the very different details of that, but we have recently funded 6 clinical sites throughout New York City with 6 agencies with 12 sites throughout multiple boroughs, so that they can provide comprehensive screening for sexually transmitted diseases and HIV as well, on-site treatment where possible, screening for substance use, mental health, and PEP for uninsured individuals. My partners are here in the room. Many of our partners are here. William from Cohen Lord is here, one of the funded agencies. And they also do on-site substance use, mental health, social service assessment and linkage if necessary. So it's an attempt to provide a comprehensive wraparound package. We were lucky to work with New York State so that Medicaid would be, the formulary would take care of PEP and PrEP. So that's been a very, very positive development. We're working on a citywide and statewide task force around PrEP, working with our academic partners, and also working with partners here in the room. TAG as well has been working with us to develop some social marketing materials to disseminate and get information out into the community. So we're working on multiple levels. One of our community partners used an analogy of a thatched roof. You know, you need to pile on as many different layers as you can because not every modality is right for everyone. And so we are adopting that approach in New York City. So I'll stop there. Thank you.
Sean, thanks so much, and thanks to the organizers for giving me the opportunity to be here and speak to you a little bit about what we're doing for HIV prevention in San Francisco. It's really quite an honor to be in this room with all of you, so I really appreciate it. So the question Sean asked was, how are we incorporating biomedical HIV prevention strategies into our programming in our local health department? And I'd first like to just emphasize that I really prefer the term biobehavioral. I think this has come out both in Ken's comments and David's comments earlier. All of these strategies that we consider biomedical have a huge behavioral component, both around risk perception, risk assessment, choice, and adherence to whatever the tool is. And the strategies I'm going to highlight really complement other things that we've been doing for a long time in San Francisco that are really key to HIV prevention as well, including condom access and distribution, needle and syringe exchange, trying to improve access to substance use treatment, as well as having access to health education and risk reduction counseling. I'm going to highlight 6 of these biobehavioral strategies that I think have really helped us achieve some of the successes we've seen in San Francisco in stemming the tide of the HIV epidemic there. The first one is status awareness. So really, we've put a lot of resources into increasing access to HIV testing. And this has been a multi-pronged approach. We've improved access to routine testing for groups with high HIV prevalence and incidence, and have a general DPH recommendation that those at elevated risk for HIV are tested every 3 to 6 months. So access to testing and access to frequent testing. Through projects like the Expanded Testing Initiative, we've worked to routinize testing in medical settings like the community health centers that have been referenced a number of times today, such that we come better into compliance with the USPSTF and CDC guidelines around universal opt-out testing. We've done policy and advocacy work to simplify the test process and looking at policies around required written informed consent for HIV testing and trying to remove some of those additional barriers. And we've also incorporated screening for acute HIV infection in high prevalence settings. So in 3 sites in San Francisco, we use both RNA pooling and 4th generation HIV antigen antibody testing in addition to rapid testing to try to find those with acute HIV. And currently, about 10% or so of our new diagnoses in San Francisco are actually those with acute HIV infection. And we know that's a population that's had recent risk, that has high viral load, and probably therefore has a higher risk of transmitting HIV infection. So through this work, we've increased the number of HIV tests through DPH by over 30,000 annually. The second program I want to mention is LINKS, which stands for Linkage, Integration, Navigation, and Comprehensive Services. And this is probably a little heavier on the behavioral than the bio, but it's really both, because LINKS is all about working with clients to get them into care so they have access to antiretroviral treatment. The LINKS program includes both partner services and linkage for clients who are newly diagnosed with HIV, as well as navigation. We have 2 health navigators to assist with re-engagement for those who are living with HIV and are not in care. And clients come to the navigation program both from referral from providers who've said, I haven't seen this person in 6 months, I don't know what's going on, and also using surveillance data to identify those who are out of care. The third key strategy I want to mention is the universal offer of ART, which was initially announced from Ward 86, the HIV primary care clinic based at our county hospital, back in January 2010. And in making that, Brad Hare and Diane Havlier, in making that policy decision, really became one of the first sites to get out in front of this decision and recommend ART for everyone on entry into care, regardless of T-cell count. And Mitch Katz, who was our health director at the time, made that a DPH-wide policy recommendation a few months later. We're currently trying to push the envelope on this even further, in that we now have some efforts in place to try to get those with acute HIV started on meds within days of their diagnosis. So rather than doing what's been typical in terms of getting that first appointment, waiting for a genotype, which could take up to 4 weeks, go ahead and getting them on treatment right away. The fourth that I want to mention, so I come from an STD background, so I can't not mention access to comprehensive sexual health services, including STD screening, diagnosis, and treatment. We have a number of sites in San Francisco that provide this, but 2 of the biggest volume ones are City Clinic, which is the municipal STD clinic, and also Magnet, which is a gay men's community health center in the Castro. DPH also supports STD screening at over 30 other sites and also in the jails. And the last 2 that I want to mention are, I think, what we commonly think of as biomedical HIV prevention, and that's NPEP and PrEP. In terms of NPEP, there's been a number of mentions throughout this about, whatever happened with PEP, why doesn't anyone use it? I think similar to PrEP, there are some certainly unique challenges to PEP access, but one that's similar is that if there's no place to get it, no one is going to use it. And for NPEP, we actually have had a program at our municipal STD clinic for over 10 years. The way the program works is clients come in who've had an exposure. Most of them, about 80%, come in asking for PEP, but an additional 20% are actually just identified through the routine course of an STD visit. They're given a 2-day starter pack, which we use using 340B pricing to have access to the meds on site. And they're given a prescription to fill the remainder of the course. Those with insurance get the meds through their insurance. Uninsured San Francisco residents are able to get the medication for free through the pharmacy at our county hospital. Patients who receive PEP are given risk reduction counseling and come back in for follow-up HIV testing. And since 2002, we've provided over 3,000 courses of NPEP at the clinic. And then just lastly, to mention PrEP. City Clinic is one of 3 sites in an NIH-funded PrEP demonstration project, the other 2 sites being a municipal STD clinic in Miami and the Whitman Walker Health Center in Washington, D.C. It's a multi-site prospective open-label study, and across the 3 sites we're enrolling 600 HIV-negative MSM and transgender women, all of whom are being offered up to 48 weeks of PrEP. I'm not going to talk a lot about the PrEP demo project here because I want to give us time for the panel, but if there are questions, I'm happy to address them. But the basic objectives of the study are to look at who's interested in taking PrEP, who chooses to use it, how long do they stay on it, how is adherence, what are barriers and facilitators of adherence, do we see change in risk behaviors, is PrEP tolerable and safe in this setting, and can we really provide PrEP in these 2 busy municipal STD clinics and a community health center. There's a lot of early lessons learned I could talk about, but I think one thing I really want to emphasize here with the PrEP is that if you build it, they will come. I think we've heard a lot today about why is PrEP uptake so slow. And I think I'm concerned about us really echoing a negative message around PrEP uptake. when we're really only a year out from the FDA approval, and I think these things do take a while to take hold. And in places where PrEP is available, we are seeing quite a lot of demand. For our demonstration project in San Francisco and as well as in the DC site, there's been a lot of demand. We've had a wait list and actually haven't been able to enroll all interested participants. So what we've really seen is there's a really urgent need to build capacity among other providers in our communities to have other points of access for PrEP. And I could go on about that, but again, I don't want to take too much time. So I think this slide is just a nice summary of San Francisco's approach to maximizing the continuum of prevention, care, and treatment. So thanks, and I think Dawn, you have some slides too.
Hey, thanks everybody. Good morning, almost good afternoon. My name's Dawn and I'm from the Department of Public Health. I'm the director of the HIV/AIDS office. And I've taken a bit more narrow focus than some of my colleagues. We've accomplished a lot in Massachusetts and I could send you that list too, but I really want to ask for your help. Because one of the struggles that I'm encountering, different than Dr. Cohen, is in Massachusetts thinking about the opportunity of PrEP as a new tool in our prevention arsenal and wanting to make sure it's maximally available, but really experiencing some of those challenges around uptake. And I appreciate what Dr. Cohen said about we don't want to sort of demonize PrEP to failure before it's even gotten out of the gate. But still, I have some very serious questions about why this has been so challenging for us, and I would value your help. So the way I've framed this is sort of HIV prevention, what's the responsibility with respect to PrEP in particular of a state health department, because that's where I sit. So what is our responsibility? So what is our current responsibility? Well, we administer state and federal funding. We fund high-impact prevention activities under 12-1201 with CDC. Our goal is to improve access to testing as much as possible in both routine and targeted frameworks, and obviously to increase the number of people who learn their HIV status in a timely manner. We also transitioned our laboratory to a fourth-generation assay. We've identified 10 acute HIV infections and provided intensive linkage to care services for those folks, and to reduce new HIV infections in the Commonwealth and hopefully in the country. But more importantly, what values guide our work and what values should guide our work? And this is really where a community engagement like this one and so many of the other ones we're engaged in are so important. Because, and I appreciate the analogy to 076 and the identification of AZT as effective in interrupting vertical transmission. Because when that happened, in my recollection, everyone was at least paying attention. People may not have been doing it right away, but man, were people paying attention. And sometimes when I go out and talk to people who are not in public health or not in HIV/AIDS about PrEP, people kind of aren't paying attention. And they're not considering that this is an urgent public health crisis. In Massachusetts, 41% of new diagnoses are in men who have sex with men. In any other population where that level of disparity was apparent and a tool like PrEP became available, I wish more people were paying attention. So we have a responsibility to implement effective public health interventions, to replicate approaches that are evidence-based, and barring the whole Debbie-Ebby conversation that we're going through now, that maybe some of those things are not going to be implemented in the same way. We need to respond to health disparities. The National HIV/AIDS Strategy says it. Every public health document I've ever read said it. It's what I was taught in public health school when I was a kid. It's sort of what we're supposed to do. And again, PrEP as an opportunity to address an epidemic that is at crisis levels still 30 years into an epidemic is something we have a responsibility to pay attention to. At the same time, our money is going away, right? And in Massachusetts, we've experienced what will be a 50% reduction in our CDC prevention award by the end of this cooperative agreement. So increasingly, all of us have a responsibility to invest scarce resources well and in a way that we can defend. And PrEP certainly is on that list, but again, we need help to articulate those arguments. And we have to leverage the opportunities of healthcare reform. So I'm thrilled that we're hearing people ask questions about, is this reimbursed? At what level of sufficiency is it reimbursed? Are Medicaid programs covering it? I'm proud to say that in Massachusetts, our Medicaid program was right out of the gate covering Truvada as PrEP, and we need to partner with individuals and communities and providers to do this right. So I can tell you a little bit about what have we done so far in Massachusetts. This is something I wish it was more. We similar to the National HIV/AIDS Strategies description that Greg gave us, we knew biomedical prevention was coming down the road when we did our most recent procurement for prevention services in fiscal year 10. So we put it in there, even though we couldn't buy it yet at that point. We knew that during the 5-year course of the contracts, it was going to become available, so that was in there. As soon as the journal article was published, the department released a position statement on PrEP. So our providers knew what we were thinking about it, what we would support or could support, and where we were headed. We convened in early 2011 a PrEP clinical advisory group, of which some members are in the room now, and certainly Fenway was there, AIDS Action's Eric Bruss was there, and others, to help us think with medical providers and community providers and advocates, how do we do this work and how do we plan strategically? We met pretty quickly with our Medicaid program, and we were thrilled when we sat down with them and said, are you covering Truvada as PrEP? They said, we have no idea. So we said, well, how can we try to do a proxy measure? So we had them run Truvada monotherapy between 2010 and 11, or 2011 and 12, and we found between 36 and 80 unique Truvada monotherapy prescriptions were covered by Medicaid. They couldn't tell us what they were for, but when we asked around, so there was some strong suspicion that some of that was PrEP, and Medicaid has committed to cover Truvada as PrEP. And then we recently released a clinical advisory about PrEP. And we're just now beginning, in partnership with Fenway and a few other community health center and safety net hospital sites, a PrEP implementation project. Because what we really want to understand is not does PrEP work, we get it, we know it works, is it feasible to deliver in community-based settings? We want to know that it's reimbursed by third parties, both private insurance and Medicaid and Medicare, and that's the kind of stuff we want to start testing. So, when I was trying to search for clip art to sort of do a visual for what PrEP was in Massachusetts, I was looking for a candle that wouldn't light. And when I put that in the search engine for clip art, nothing came up. But we do have this opportunity, and we feel like it's knocking on the door. We have had lower than anticipated demand. We do know that in Massachusetts, because of the research sites and the academic medical centers, we have some ongoing research, but very limited real-world experience, and we want to test the extent to which the provider capacity is an issue. We haven't heard it explicitly, but yet we're not seeing a lot of uptake, and we're hearing anecdotally from the community that there's not been a lot of proactive offer from providers. So we do want to make sure, to the point about capacity building, that is available, and to the extent that we can partner with others to do that, we hope that's our plan. So that's a little bit about what's going on in Massachusetts. And so the last slide I have is sort of, when answering the question, why might the uptake not be what we want it to be, there's something I've started to call the complex web of authority with respect to what happens when public health and medical doctors and consumers and advocates and policymakers and health insurers all get in a room together and try to make a statement about whether something should happen or not. And I wonder to what extent some of these issues are all sort of coming together in the decision-making process and just creating challenge. Doesn't mean they're insurmountable, but we need to figure out sort of if the state health department is going to do something, and sometimes we've been accused of not doing enough, what does it need to look like, and how can it be respectful of the dynamics in this web that are playing out for people who are making really hard decisions in real time? So I look forward to the discussion.
So we'll go to questions from you all in a minute. So my understanding of what the three of you presented is that you're seeing significant demand stuff in San Francisco. You said there's a wait list. And it seems like there's a lot of awareness among gay, bisexual men, transgender women in San Francisco, and that there's less demand, less uptake in New York and Massachusetts, right?
Can I speak to that?
Please.
I don't know, should I speak to this or this? I don't know if people use this?
Use that
Okay.
as well.
Can you hear me?
Definitely
Okay.
can hear.
Okay. I didn't want to bring all of this data out in my little intro, but we do have some data in New York City that's sort of coming online, various small surveys that have been conducted. And the way I guess I would characterize it in New York is moderate awareness, low but increasing provider prescribing, and so increasing as the trajectory that Ken described is happening in New York. If we have a survey that we do every 6 months of gay and bisexual men who are at risk, venue-based and online. And we asked about PrEP awareness. Now, these were before the FDA approval. So we had about, across fall 2011 and fall 2012, about 36 to 38% of MSM who report some sexual risk were aware. I would call that, I guess, moderate and could increase, but not too low. In terms of use, in the fall 2011, and again, this was prior to FDA approval, only 2% reported using PrEP, but by fall 2012, 10% of the sample of those who had heard of it were using it. So again, an increase, and before FDA approval. More recently, in our STD clinics, we've been doing a survey called Preparation for PrEP. And we asked New York City residents over age 18 who were eligible for acute HIV testing. And we screen for using pooled NAT testing, all MSM, and then other people who meet certain eligibility requirements. And again, about 40% had heard of PrEP. And after watching, we show them a brief video that educates them and explains what PrEP is. And after watching it, 71% they were somewhat or very likely to take PrEP. There's also been one other survey I just wanted to mention by Jim McMahon, who's from Rochester, a very small survey of medical directors. Now, these were, again, HIV clinic directors. So there is this disconnect that people have been describing between HIV doctors knowing the most about it, but the primary care providers being the ones who would be likely to prescribe. This was among HIV medical directors, 21 medical directors representing 176 medical providers. About 8 out of the 16 that said that they knew whether this was happening or not, half said that there was PrEP prescribing in there, in the orbit of doctors that they knew. And that was up from the year before, 11% the year before. So we are seeing increases in New York, but again, these are very, very small surveys. One last thing I want to mention is, we talked about training the right providers. One of the things that we're trying to do is we've developed a CME course for primary care providers and emergency room physicians, and so family practitioners, internal medicine, general medical practitioners, around biomedical prevention, PEP, PrEP, and early antiretroviral therapy. We did the first one in May, and this week that was in Manhattan and with TRIPS assistance at Cornell. And we're doing one this week up in the Bronx, and we're trying to reach all of the outer boroughs, and we're trying to specifically focus on primary providers so that we can address this disconnect between HIV docs and primary docs. Oh, whoops.
I just want to clarify one thing on your comment. Is this on?
I think so.
Okay, because otherwise I know Joanne will stand up. Yeah, she's got the mic already. So I think uptake in San Francisco, we have not seen a lot of uptake among transgender women, and that's certainly a population at a very high risk that's not been participating in high numbers in the demo project or in other points of PrEP access. A couple other things just to quickly mention about why I think we have seen demand in San Francisco. One is I want to mention San Francisco AIDS Foundation and the great work they've done in terms of increasing community awareness. They actually launched a big PrEP awareness campaign right at the same time that the demo project was starting, and hosted several community forums where there were discussions on PrEP. And I think this has generated a lot of word of mouth, and I think there is a real snowballing kind of spread about PrEP knowledge that happens, and perhaps we have to get past some sort of tipping point before that sort of level of interest starts exponentially increasing. Just in the demo project alone, we've had a number of participants who've come in referred from other participants, so we know that that word of mouth spread is happening, and I think it's important.
Okay, so thanks for clarifying that, Stephanie, because I think that is, where we trip ourselves up when we see the, data presented and it says MSM and transgender women, but when in fact, when we look at the number of trans people who are enrolled in the studies, for example, not to put you on the spot, but at City Clinic we have 2 who are lost to care, right? So trans women in San Francisco involved in this PrEP study. So I think that is, a problem. The other thing that I would say is that in San Francisco, we've seen actually an increase in prevalence among trans women from the time when Kristen Clemens Knowles did the epidemiologic study with San Francisco Department of Public Health, where we had 35% overall prevalence among trans women. And now the TEACH study findings showed a 39% prevalence, 13 years later. And so I think that, we need to be careful about how we're presenting the data and about the assumptions or conclusions we're reaching when in fact the data tells us something else.
Thanks, great panel. I have a couple of thoughts that have bubbled up from earlier and then with your panel, and especially thinking about the role of health departments. First, the overarching idea is, we talk a lot about linkage to care, the cascade. It would be nice if we started talking about linkage to care for negative people, the cascade for everybody in our community, and keep people from ever having to enter the HIV cascade. And PrEP is a piece of that. So I'm wondering what health departments might be thinking in terms of, especially with the new opportunities around the ACA, more access to care, access to PrEP as one piece of that potential care. And I also I get concerned when we say there's waiting lists or where PrEP is available. PrEP is available where anyone can write a prescription, where anyone has health insurance or Medicaid, or knows how to get on the Gilead website and access their medication assistance program. So it's actually available everywhere. It doesn't need to be in a project, implementation, demonstration, as important as those are, and we need to figure those out. If someone wants PrEP today, they can be in whatever part of the country and get it. And of course, there's huge issues with providers and stuff. And then it'll lead me to my final comment. I think it's got to come from the community. I think our demand has to come. We're going to be the ones who lead it. It's not going to be providers offering, because they're not going to. Even in the best of cases, I don't think they will do it all the time. But if we're coming in demanding it with fact sheets saying we know about this, if the person who counseled and tested us and provided us with an HIV status of negative mentioned, hey, have you heard about PrEP? Here's some information, and got the ball rolling there, I think that's going to lead to a lot more uptake. It's going to come from the community, from bottom up, from grassroots up. It's not going to come from providers down.
Yeah. And just taking the last piece of your question, Jim, just what should the role be for the health departments, and what should the role be, given who's in the room, for community-based organizations, for the LGBT advocacy groups, the AIDS advocates and the AIDS service organizations, and the health centers that are focused on LGBT populations?
Right, so that's a lot of questions. I mean, just here to your comments and your questions, because I think it's exactly right. And I do think to the extent that the community starts to sort of increase the demand and spread the word and sort of buy-in among folks for this as an intervention that they trust and that they feel is valuable is really, really critical. And health departments cannot do that. But what we can do is there's a few things in Massachusetts we've really tried to do. Is one, to the extent possible, whether it's our CDC prevention funds or our Ryan White resources, is to integrate those funds and those supports into the mainstream healthcare system. Because we didn't want to silo or ghettoize or separate out what was available for people living with HIV or people at risk or gay and bisexual men or trans women, that we wanted the healthcare infrastructure to be responsive to everybody. But a piece of what we'd like to do, and that we did after the 2006 CDC guidelines around routine testing, is to partner with those clinical sites and find champions who can say gay men's health matters, trans women health matters, routine testing matters, and because they really can help drive practices in partnership with community, and then also to come to the health departments when there's a gap, when something's missing, when they need either funding or some other kind of institutional support to really make it happen. That's where I hope we can be helpful. So that's sort of where I feel like, and to the extent we keep putting out policies and clinical advisories and things like that sort of move the train along, we'll continue to do that. But I think with an issue like this, we really want to get in the weeds and really help make it happen. We tried to do that with routine testing, and I think PrEP is another place to do it.
I say here as well. Many things I'd like to say. I have to try to limit a few of them. First of all, with testing, you raised the point about generating demand. There's a sort of supply and demand issue. We really tried to do the same thing with testing through our community mobilization efforts with Bronx Knows and Brooklyn Knows. You'll see that all of our social marketing said, ask for the test. And the idea was, from pharma, ask for that purple pill, right? Everybody remembers that ad with the purple pill. So not only would we try to educate providers and normalize routine screening from the provider end, but also from the consumer end, so that you come at it from both directions. And I think that's very, very important and can be applied here very much. I also think we all know of the EBI called POL. Right? We all need to be POLs in our own sphere. Popular opinion leader. So you need to be a popular opinion leader wherever you sit. If you're a provider, I think you had mentioned the AAMC had left out LGBT in a particular screening survey, and you were a POL by asking, why did you leave that out? So little questions like that, or what seem like little questions, can make a huge difference. They can shift everything. We've tried to talk to CDC and New York State about the two-step question to get better data around transgender health. So that seems like a small, tiny, wonky epidemiologic thing, but it makes a huge difference because we can then capture the real data about what's going on with transgender women in our city and state. So I wanted to mention that. And finally, one last thing is I agree with what you had said about our grant funding really should be reserved for individuals who lack insurance or where there is a gap. So with testing, we did a lot to roll it out in the beginning. But now what we're trying to do, we're shifting our funding and we're reserving, even on the prevention side where there isn't a formal requirement for payer of last resort, we have put into our contracts that this money is reserved for individuals who lack insurance or another way to bill for HIV screening. Because we shouldn't, the resources are so limited, we should reserve these grant funds for those purposes.
I know we need to move on to other questions, but Jim, I also just want to say I totally agree with you, and I think it's notable that even in San Francisco, where we have pretty high provider awareness about PrEP, Truvada is covered not only by Medicaid and many insurance plans, but also by Healthy SF, which is a low-income access program. Even in San Francisco, it's been difficult to find providers who are doing PrEP, and that's why we have the wait list. We also have clients on the wait list who've said, look, I don't feel comfortable talking about this with my doctor. I'd rather wait for the demo project. That's a barrier as well. But one thing I think health departments can do in collaboration with CBOs is really try to put together prevention resource maps and map out who are the providers in your community who are already doing PrEP and what insurance do they take, where's the clinic located, and in providing that sort of resource list, we can then link people who are HIV negative and at elevated risk to the services they need without the health department necessarily being the deliverer of those services.
I just wanted to add one more area where community agencies and everybody can be very helpful is using your own social media channels to spread the word about resources and information that you have in education.
Hi, I want to make a small public service announcement and pick up on something that Jim said about PrEP theoretically being reimbursable and available. Ever since the information got shared about Florida Medicaid last night, it's been stuck in my craw because my understanding of Medicaid statute is that if a state participates in the Medicaid program and provides prescription drugs, they must cover all FDA-approved prescription medications and they participate in the rebate program. They must cover those medications. They can't decide to exclude a medication with very limited exception to that. And so I've been emailing and trying to verify this and just got word back that actually Florida does cover PrEP. It just needs prior authorization. We can all decide that prior authorization is a barrier, but by law, states can limit the duration and scope of their Medicaid prescription drug programs, and Florida does that with prior authorization, but it is covered. So I would just urge anyone, if they're hearing that their state Medicaid program is not covering PrEP, they should let CMS or let some of us know, because we can pursue that, and I don't think that actually should be able to happen. Thanks.
That was a great discussion, and I just want to first acknowledge that you three are success stories, right? You've used treatment in testing in combination with other things, and infection is falling in each of your jurisdictions. And I think we need to do more to try to understand what you're doing right and how you did it, and realize the the question about how to use ARVs in prevention isn't just a future-oriented question. You're seeing the success now. And I guess what I wanted to ask is a kind of impossible question, but I'd just love to get going, because I'd like to see you all write a piece that tells us what the core things were that started the success. But let me ask you, if I was in a state that was, ACA was coming on, I had just expanded my Medicaid, I wanted to do the same thing you did, bring HIV incidence down, what were the one or two things you'd say to me about what you did that you think was most critical?
So, I really appreciate the question, and I want to pick up on something you said about a future orientation in terms of reflecting the successes that that our jurisdictions have seen. I would say in Massachusetts, and two former HIV/AIDS directors are in the room, Dr. G. McGuire and Kevin Cranston in the back of the room, that it was historic decisions that actually impacted our success today. So it's a 10-year decline in incidence in Massachusetts. It started back in 2000. In 2001, our state was able to expand Medicaid for low-income people with HIV, irrespective of disability status. That was probably the turning point in Massachusetts for improvements in health status for low-income people with HIV infection, and where we also started to see declines in incidence. In 2006, we accomplished state health care reform, which made health insurance coverage accessible to all Massachusetts residents. By and large, over 98% of Massachusetts residents are insured. And so I think it was the benefit of those two huge policy decisions and expansions that drove down our incidence. We have an HIV drug assistance program that has an eligibility ceiling of 500% of the federal poverty level. So that's a very high eligibility ceiling, and it means that for people with HIV who do experience any kind of cost barriers to getting medications, we can help them with that. And so maximizing access to care and treatment. And then the first thing I said in my last set of comments was that we always infused our resources, whether they were state or federal, into the existing healthcare infrastructure. And what that has enabled is that, by and large, the community health centers and safety net hospitals or major medical centers in Massachusetts are good at serving people with HIV. They've grown they've developed real solid expertise in doing that. And so I think that has helped tremendously.
I agree with all of those things. I will add a couple points. I'm going to paraphrase Bernie Branson from the CDC. He might not really like that I paraphrase him, but he said that the two things that really get people to change are changing the law and money. And we have really pursued structural legal change in New York. And we also, I think it's no accident sitting next to Massachusetts, both of us have very, very broad, encompassing social supports in terms of Medicaid, ADAP, with no waiting lists. And if you look at places in other parts of the country, that's not the case. So we've tried to integrate as well with routine clinical care. The best example of that is our near elimination of mother-to-child transmission, where routine screening of pregnant women, we passed a law early on in the mid-1990s requiring, again, the counseling and testing of pregnant women. And that law took a number of years to take effect, to have impact, but over 5 to 10 years, we now have 3 babies in the whole state. And it was perceived to be standard of care to screen pregnant women for HIV because of those changes. So a combination of structural legal change, having the broad social support, whether it's through the Affordable Care Act or Medicaid, ADAP, so that there are no barriers in terms of payment for marginalized or vulnerable populations, and also integration into mainstream care.
Okay, great. We have time for one more question. Charles Stevens.
Yes, I was wondering, related to the structural factors around ARV-based prevention, I was wondering, in thinking about on the institutional level, I was wondering if you guys paid any attention to perhaps institutional practices that might facilitate success around ARV-based prevention, around actual organizational practices, norms, how job descriptions are written, how folks are hired, things like that. And also connected to that, I was wondering, I know that, with as the HIV prevention landscape has evolved, there's, obviously less attention paid toward group level behavioral interventions. However, there was also considerable capacity built around that. And I was wondering, with staff that might have been very successful at group level interventions, particularly like frontline staff, like especially like young Black gay men and bisexual men, I was wondering, have you piloted any programs to like retrain them, or how are you working with staff that had lots of capacity related to group level interventions as we move more toward more ARV-based prevention and PrEP and so forth?
A couple things I could say there. I guess there's two separate questions. One is infrastructure, and the other is, I might take the second one first. We've done a couple things. First of all, while we have shifted away from individual and group level evidence-based interventions, we've embraced community level interventions. We have seen some impact there, and we reach many more people, and we try to integrate it as more of a community mobilization effort to get people also tested and linked to care. So we fund several agencies that specifically try to reach young gay and bisexual Black men through community level interventions. Bringing in those other pieces and having them part of many other activities. Also, we have worked with agencies to try to get people to retrain toward linkage navigation. There's a lot of navigation of the health system. Health system is very complex and decentralized. And so that navigation piece is very, very important, as well as the outreach piece to bring people in. And one way we've done this, and I think our agencies in New York, Guillermo Chacon is here from Latino Commission on AIDS, and several other of our partners are here in the room. They've really been on the forefront. They've really been thinking outside of the box. And you know that there have been a lot of mergers and partnerships in New York. And a lot of clinical, non-clinical entities, or bringing clinics on site into the agency. And these have been very, very important structural shifts. I think I'll stop there.
Yeah, thanks, Blayne. I think one thing that health departments can do to help inform this is really use surveillance data to guide CBOs and to give feedback to CBOs around some of the efforts that they're doing. And I think that's one of the ways in which our health department is trying to better work with groups that are reaching out to those most at risk. Yeah.
I would echo what Dr. Cohen said. We're also increasingly using surveillance data to inform program response, and we're doing it explicitly by using our disease intervention specialists in different ways than we ever have. Our acute HIV infection response protocol is an example of that, where people who were newly diagnosed as acutely infected with HIV received an intensive outreach intervention from our disease intervention specialists, but in partnership with preventionists, with people who are either doing counseling and testing or doing behavioral prevention work with clients in the community who have some of the training that you were referencing. Our HRSA SPINS project actually partners an HIV positive peer with a nurse to go out and do some of this linkage work. So I think, and there was reference earlier to sort of the blending of Ryan White and CDC programs. We've increasingly tried to co-locate our prevention and care investments in the same places, so that leveraging kind of happens naturally as part of an interdisciplinary care team. And it's not about sort of which box do you check off where the dollar went, but it's about leveraging all those investments to do the right thing for clients.
Great, thank you, Don Fukuda, Blayne Cutelr, and Stephanie Cohen.